Spill the Health, Real Talk, Real Health. Today we are very privileged to have our respiratory physician, respiratory specialist with us, Dr. Wan. Hello, Dr. Wan.
Hi, Richard. Thank you for having me here for this podcast recording here. Thank you for the invitation. Let's discuss something regarding respiratory health today.
Yes, Doctor. Doctor, we know that you take care with a respiratory system. So basically for your day-to-day task, what do you actually handle?
Thanks, Richard, for having me on the show. My name is Dr. Wan. You can call me GL for short. I'm actually a respiratory physician, or some call us pulmonologist. We are dealing with a lot with lung health or any ailments in the lung. So I do a lot of diagnosis and testing for patients who have lung diseases. We do everything ranging from asthma, chronic obstructive pulmonary disease, which are known as smoker's lungs, and all the way until diagnosis of lung cancers as well. And lung growth, yes.
Okay, so if let's say people have cough or maybe tuberculosis,
yes.
they should also see you.
They can come and visit the chest physician or the respiratory physician for further testing, to get further diagnosis on their respiratory ailments. So that's basically in a nutshell what we do. We see them, we take some histories from them, do relevant investigations, check their phlegm, or even do a camera test for them in what we call by a bronchoscope for them, if necessary, to come to a tying diagnosis, so to be able to know how to treat our patients who are having these symptoms.
Okay, thank you so much, Doctor. Doctor, how do you differentiate yourself from an ENT?
Okay, that's a
so
good
for example,
question.
if I have cough, should I see an ENT or should I see a respiratory physician?
I think in general, there is no right or wrong which doctor to see. I think any patients who have a problem, they will come to the hospital. Sometimes it can be co-managed. We live in a place where respiratory and ENT, we work synergistic. We work closely. That's right. Usually, in broad terms of coverage, the ENT, their ear, nose, and throat, they see more towards the upper airways, and the lung doctors or the respiratory physicians, they see more to the lower airways. And but anyhow, any patients who come with any problems of cough, they can be seen by both, and when necessary, we refer to each other.
Okay, thank you so much,
That's
Doctor.
right.
I believe that actually clear up our thoughts, because now we have ENTs, we have respiratory physician. Now you guys know what's the difference, yeah? Okay.
Yeah.
All right. So talking about advanced lung diagnostics, recently we heard of a new technique called EBUS.
Right.
Yeah. So, Doctor, can you tell us more about this EBUS?
Okay.
What is it?
All right. I think the one thing to know is medical technology has always been progressive.
I agree.
It progresses year on year, and newer technologies come out to better diagnose, to better stage patients who have lung cancers. So in summary, I would say this term, like what you mentioned, EBUS stands for Endobronchial Ultrasound. It is a short form. EBUS is a short form for Endobronchial Ultrasound. So what does it mean? So at its core of this terminology, EBUS is actually a specialized procedure that actually allows us doctor to see more clearly structures inside the lung. Now, it's actually a combination of what we already know, what we call by a bronchoscopy examination. A bronchoscopy examination means that there is a small little flexible tube with a camera at the distal end to see what's inside the airway, what's inside your windpipe. And an ultrasound is basically your ultrasound. It's like it generates sound wave to have a better live feed image on what is behind this airway, behind these lungs that we cannot be seen on a normal conventional bronchoscopy examination. So if you combine these two, what you have is actually what we call by an endobronchial ultrasound, which means that you have a camera at a distal tip of that flexible tube and with an ultrasound attached to it. Sounds very
Cool.
hi-fi.
Yeah, very
It's not
high-tech
very
and-
hi-fi actually. I think this technology has been around for some time. And it's just that because cancer treatments now, why it becomes very important? Because cancer treatment now, we have many stages. So every staging is very important. Every stage is relevant to know so that we can tailor the treatment for the betterment of the patient if we know each staging properly. So the function of the EBUS actually mainly is to stage the patient well so that they can benefit from the appropriate treatment based on the staging.
I see.
That's right.
Doctor. Wow, it sounds really cool, and I think it's quite advanced, lah. Well, doctor, so how does this EBUS different compared to the normal things that we see for lung screening, for example, chest X-ray, CT scan? What sort of information that EBUS can give, and these two, like chest X-ray and CT scan, can't give us?
Okay, I would say a chest X-ray or a radiography examination. A chest X-ray is like, let's put it this way: if you have a house, you take a picture of the house, that's the X-ray.
The exterior.
Yeah, the exterior, that's right. A CT scan is like seeing what is a better, clearer picture of what is inside the lungs. It's like seeing a better, clearer picture of the house. Now, sometimes when you want to see a better view of what's inside the house, the structures behind it, now you can't see that. Now, that's where the EBUS or the endobronchial ultrasound carries some weight there. Because of the ultrasound that's been attached to the distal end of the flexible camera tube of the bronchoscope. Now that gives us an opportunity to see live feed any images that cannot be seen on a conventional scope. Now we can see that live now in a black and white picture when it's being generated according to the sound waves. So when you put an ultrasound there, there's a sound wave being emitted, and that shows us what's behind these structures. So we can better take samples from this kind of abnormal growth that is seen.
Okay, I really like the analogy. So it's basically like if, let's say, our house got some issues on the wall and we want to check it. So we use a scope to actually check it to see actually what is wrong with the bricks or maybe with the cement inside. So it's something like that.
It's something like that. So what it can do is it sees behind things. Now, EBUS allows you to see what's behind it. So because this is a type of technology that transmit ultrasonic waveform, and that gives us an image to see behind structures. Now that's something very relevant because there are many structures that cannot be seen on a normal bronchoscope or a normal flexible camera testing. That's what we call it. Yeah.
Okay, now we understand. So Dr. Wan have actually give us a very good analogy. So now I believe that you guys know more about EBUS lah. Okay, now just now we talked a little bit more about biopsy, because just now, doctor, you said that it's more like a more advanced way of doing biopsy, especially for lung cancer. If you compare some of the ways that we actually use to actually biopsy people that have lung cancer, how does EBUS outshines from every other techniques?
Right, that's very I wouldn't say outshine. Now, every single technique in biopsying growth, as long as it gives you an answer, what kind of growth is it is good. Now, what additional benefit
Yes.
that EBUS offers. Now, EBUS offers us an opportunity, I would say an opportunity to biopsy something which is not clearly seen in the airway. It biopsies things behind the airway. So you want to biopsy something behind the structures. Now, if you see our lungs, our chest wall, inside our chest wall, we have complex anatomy. We have many things going behind the chest wall. It's not just the lungs. There's airways. There are blood vessels. The heart is pumping, so there are a lot of vessels in the lungs. There's also what we call by lymph nodes. Now, these lymph nodes carry a lot of weight when it comes to staging. A person may be stage 2, stage 3 in lung cancer staging with different lymph node involvement. So, how does EBUS carry weight in this kind of patients is where EBUS allows us to see behind the airways, to put in a fine needle through that bronchoscope to biopsy it real time.
So whereby normal bronchoscope
Cannot reach. Exactly. That's right. When you do that, it is not as invasive as the previous, or what we call by the previously procedures that was being done previously, which we call by mediastinoscopy. So these are very minimal. EBUS is a very minimal invasive procedure. You can do it as a daycare procedure. Patient comes in to the daycare, they were fasted the night before. We put them on a moderate sedation, giving them some medication to make them feel a bit drowsy. So they are into like their twilight of their sleep like that. Not fully, they don't need to be fully general anesthetized. They have the option to do that as well. But usually we do it as a daycare, so it's a very quick turnaround. We can put the normal, we put in the EBUS scope in through the mouth usually. And when we see any abnormal structures, we'll just put a fine needle through it to take some samples from that particular lymph node. It can be even a growth in the lungs which cannot be seen in the airway, and that needle can pass through the airway into the growth as well. So that does not only give us the opportunity for a very minimally invasive procedure, but it's a very safe procedure as well, actually. Yeah.
Okay, all right. So I believe that the audience out there, you guys now know that it's not that scary, okay? It's pretty much very similar with your gastroscopy or your endoscopy, whereby you will be, you have light sedation, and then after that, doctor will just go inside you, and then you'll be sleeping there. So you don't need to worry about being painful, yeah, doctor. Yeah.
I think there is maybe some misconception that these things are painful, these things. I mean, they're
because people will be scared, especially when they found out that, I might have lung cancer. Now I wanted to do biopsy. I'm so scared. So I do see patients, they are so scared until they say that, I'm so scared, I don't want to do this biopsy. Or maybe they will choose, okay, doctor, can I choose a finer needle, not that big needle? So that's the reason why, doctor.
And that's the reason we need, so that's the reason why we need to educate the public. And I think that the public should know that there are many other ways now that we can sample these lymph nodes for diagnosis and for staging as well. And sometimes we can even take samples of the growth itself rather than if we take it from what we call by CT guided biopsy or ultrasound guided biopsy from the outside in. We can do it from the inside out. So in the gist of things, it's just when we put the scope in, we will turn on the ultrasound from at the distal end of the scope, and then once we see the sound waves penetrate the wall of the airway, this gives us a live video feed of what's going on around it. We can see blood vessels, we see the lung, we see all the lymph nodes, and when we spot any abnormal things there, and that's where we will put that needle through and just sample it. So one particular lymph node, usually we will sample it about minimum 3 times, but usually I do about 5 to 7 times to ensure that we get adequate samples as well. And usually they will come with a little bit of minimal bleeding, in which that usually it will stop on their own.
Okay.
Yeah.
Sure. Thank you so much, doctor. Is there any risk associated if, let's say, a person is actually, they actually need to use this EBUS for the procedure? Is there any risk?
Any procedures comes with risk. I think it's just that how we stratify and how we grade this risk. I would say this is a relatively safe. Essentially, EBUS is actually a very safe procedure. I would say it carries some minor risk. Minor risk like bleeding, which is because we pass a needle through to sample what is behind the airway, to sample anything. We are poking through things, so there will be some bleeding. But usually this bleeding will be stopped on its own. Of course, we have other ways that we can control this bleeding by giving some medications while we are doing the procedures. But usually in general, bleeding is quite manageable. The other second thing, which is also carries a minor risk, is what we call by pneumothorax. Is because when we pass through anything, we puncture, our lungs are all having a lot of air. So they are all tiny sacs of balloons in our lungs. So sometimes when we pass through to sample our abnormal growth, and that's where sometimes these lung small little sacs burst and they cause this called pneumothorax. But these are actually very, very minor risk. They occur, but it's not the very serious type. So it's manageable usually.
Okay, doctor, thank you very much for your explanation just now. So if, let's say, someone wants to do EBUS, just now you have told us that they will come here, it's a daycare procedure, right? So how long usually will the procedure for EBUS take?
Right. So generally, if we do under moderate sedation, which means that the patient comes in, we just give them a little bit of sedation, the medication to let them make them feel sleepy, but they are not fully asleep. If we sample one lymph node, usually it's quite quick. It can be done as fast as about 25 minutes. Then after that, when you remove the EBUS scope, then the patient, we will let them recover in the recovery bay. So the total procedure can be as short as about 25 minutes. But in general, if we want to do proper staging, it will take, if you sample more lymph nodes, it probably can take up to 40 to 60 minutes as well. So I would say it's approximately half an hour to an hour for the procedure.
That's actually pretty quick.
Yeah.
So doctor, if let's say a patient have lung cancer, how do you decide whether the patient should actually use EBUS or maybe they should actually use other way of biopsy?
So what I would do is when we have a patient come to us, there's a growth detected. Usually they have already done some form of scan, a CT scan. We will put them up for a PET CT first, a PET scan first, to see any lymph node involvement. Now, if the patient is already, they come with like stage 4, then you do not need it. But we focus a lot EBUS, especially when these patients are early stage. When you think that these patients have a chance for curative surgery, now before you go in for a major operation to remove the tumor or remove the growth, we want to ensure that no growth or cancer cells has been spread to the surrounding lymph node structures. Now, how do you sample it? That's where EBUS comes in. Very minimally invasive. We will just go to the lymph node which are seen on the PET scan, and then we will sample it, and then the results will be out usually within a few days, sometimes as early as 2 days. If there are more tests to be run, it probably takes up to 5 to 7 days, but in generally the results are out very quickly.
Okay, thank you so much, doctor. Doctor, if there's one take-home message that you would like the audience to take home, what do you think it is?
EBUS is generally very safe. We have come a long way in terms of lung cancer staging. It is an essential tool now to stage our cancer, especially lung cancer, properly. Especially when you're going for surgery or you're going for treatment, we will want to know this staging well. And that's where I think EBUS plays an essential role in this. It's minimally invasive. You don't need to go for a major surgery to put in a tube behind your breastbone. We do it as what we call by mediastinoscopy. We do not need that kind of invasive procedure anymore. So this is a very quick procedure, minimally invasive, not very high risk, and it can be done as a daycare procedure. So I think all this, that's look forward to for patients who just recently get diagnosed of lung cancer to get a proper staging.
Okay. Thank you very much, Doctor,
Yes.
for your time. Spill the health, real talk, real health.